we'll move to the questions. I'm taking some questions here. I prefer that the person who's giving the questions is to talk. I mean, I'm going to introduce each one to talk and ask you a question directly. So I have Arwa Badib from King Abdulaziz University in Jeddah, and she wants to give you a question. So Arwa, you are the only one who's allowed to unmute yourself. Please unmute and speak.
Hi, how are you doing?
Hello, hi.
Hello? How are you? I had a question for you. When I used to train, we were on the eastern part of the States. So when I trained, we used OPTN quite heavily. So I went from residency using OPTN and then to fellowship using OPTN. So now going back home and wanting to establish something, and I think LI-RADS would be a more comprehensive way of doing things, because OPTN is pretty much what is established in the US, and probably it's not internationally known that much. My question to you is, how do I transition from learning all about OPTN to LI-RADS, and how do they, what are the similarities between the two, and what are the differences in terms of reporting, in terms of language use, and all that stuff?
Thank you for your question. OPTN is the Organ Procurement and Transplantation Network. It's a society in the United States that creates the policy for how organ transplantation, including liver transplantation, is performed in the United States. The focus of the OPTN system is to decide the priority with which liver transplants in the United States can be done for patients with liver cancer. So OPTN is an excellent system, but it really only applies in liver transplant patients in the United States. And because it's geared towards liver transplant, it's a binary system. So a lesion is either an HCC or it's not an HCC. So that's an appropriate system to use in the setting of liver transplant, but it's not a comprehensive enough system to use in the setting of all patients with liver disease, the vast majority of whom will never have a liver transplant. So only a minority of patients that could potentially get a liver transplant would ever get a liver transplant. And for the vast majority of patients, we need a more comprehensive system.
Please, everyone unmute yourself except Claude only, and maybe Arwa now. But everyone else, please mute yourself. Yes. Thank you. I know that Corona is affecting us, so we're living now 24/7 with the kids, which is crazy, but yeah, thank you. Go ahead, Claude.
Yes, no, thank you, Khaled. So, so just to get a little, maybe I'm getting into too much detail here, but OPTN is an excellent system, but it's really geared only for liver transplant patients. It's just simply not geared for all comers. So LI-RADS is a more comprehensive system and is designed for use in all patients, those who are liver transplant candidates and also those who are not. In terms of the similarities for the diagnosis of HCC, the criteria are quite similar. It's just that if it's not an HCC for OPTN, then it doesn't exist, whereas for LI-RADS, there's a process where you can characterize things that aren't definitely HCC. In terms of how to get started, what I would say is download some of the materials from the LI-RADS website. Please, participate in some of these webinars that Professor Elsayes has very kindly organized, and you'll learn a lot more about LI-RADS from the lectures that follow. And then I think just start using it at your institution, and I think very quickly your clinicians will appreciate the fact that you are communicating with them very clearly, and they will understand your reports more clearly than they would if you're not using a standardized system. Anyway, it's a great question, and if you have additional questions, please, reach out to me, and I'd be happy to communicate via email with you afterwards.
Much appreciated. Thank you so much.
Thank you very much, Arwa. A second question we have from Brazil, Daniela Parenti from Rio de Janeiro, Brazil. Daniela, you can go ahead and speak, please.
Hi, thanks for the wonderful lecture. I really appreciate it. I just have some doubts on the LI-RADS classification for the infiltrative HCCs. So sometimes I want to call it LI-RADS M, sometimes I want to call it LI-RADS 5. And if there is thrombus in the vein, it's easier, so I call it LI-RADS 2. So I wonder if you could clarify.
Yes, so liver cancer with an infiltrative appearance is a very complicated topic, and it's one in which there's not a lot of scientific evidence. So what the approach that LI-RADS has taken for now is that if you see a mass that is infiltrative and the mass does not meet LI-RADS 5 criteria, so if the mass looks infiltrative but meets LI-RADS 5 criteria, then you can call it a LI-RADS 5. If a mass looks infiltrative and is invading a vein, then just as you said, you call it LRTIV. If the mass is infiltrative, does not invade the vein, and does not meet LI-RADS 5 criteria, and you'll learn more about LI-RADS 5 criteria tomorrow when Professor Cherniak gives her lecture, then you call it a LI-RADS M. Now, if you believe that it's an HCC, then you can say LI-RADS M, likely an HCC. But if you're not sure, just call it LI-RADS M, malignant, non-specific, consider biopsy to make the diagnosis. I hope what I'm saying makes sense, but you've correctly pointed out an area that needs more research, and we don't yet have a perfect system for dealing with cancers that are infiltrative. So if there's anyone on the call right now who's listening in, I would say that this is an area of research that could be quite important. So I encourage people to do research into the appropriate categorization of infiltrative masses. I hope I answered your question. It's an excellent question, and basically we need more data.
Yeah, thank you, thank you.
Thank you very much, Daniel, and I wish the best to Brazil to return back as strong in soccer as they were. Anyway,
yes,
so,
me too. Thank you, and for all of us.
So there are some questions here which I can just mention them. Some of them are you have already answered them in your lecture. So somebody saying, does LI-RADS apply to cardiac cirrhosis? So I think the question is no, it does not apply to cardiac cirrhosis. Correct, Claude?
Correct.
The other question is also you mentioned, somebody told you mentioned LI-RADS apply to hepatitis B. Why it doesn't apply to hepatitis C? I think it applies to hepatitis C, but I think his question is it applies to non-cirrhotic liver in chronic hepatitis B. Why not with chronic hepatitis C? I think that's what he wants to say.
Yeah, so this is a very important question. So LI-RADS applies to patients who have cirrhosis due to hepatitis C. It does not apply to patients who do not have, who have hepatitis C but do not have cirrhosis. then the question is, why not? And the answer is that we simply don't have the scientific evidence yet to say whether LI-RADS does apply in patients with hepatitis C before they have cirrhosis. We know that the patients with hepatitis C who don't have cirrhosis do have a slightly increased risk of getting HCC compared to the general population. The question is the risk high enough for LI-RADS to apply? And the answer is it might be, but we don't yet know. So this is another area where we need to do more research. Is it possible that LI-RADS would apply to patients who have hepatitis C and have, say, bridging fibrosis or stage 2 fibrosis but don't have cirrhosis yet? It is possible that LI-RADS does apply in those patients, but we just don't have the evidence to prove it, and so we are not yet recommending the use of LI-RADS in patients with hepatitis C who have not progressed to cirrhosis. For those in the audience, again, this is a great area of research, and I would encourage people to try to do research to see whether LI-RADS applies in other chronic liver diseases other than hepatitis B before the development of cirrhosis.
So thank you, Claude. And other questions, is the pediatric lexicon already available for download? That's a question.
It's not a lexicon, it's recommendations. I don't believe it's yet available for download. It's been submitted as an article to Radiology. We're hoping that it will be published by Radiology sometime this year. Our intent is after the publication, we'll make the consensus recommendations available, but I don't believe they're available yet through the website. But please stay tuned. Hopefully by the end of this year, they will be available.
Another question from Shaima Shusha. I think she's from my homeland, from Egypt. She's asking you how to differentiate between multifocal HCC and intrahepatic metastases from HCC. See, Egyptians are sophisticated, Claude.
Yes, very sophisticated questions. So that's a great question. How do you differentiate multicentric HCC from HCC that has metastasized to the liver? LI-RADS does not address this issue, in part because we don't yet have great scientific evidence to know how to do this, and also because it's not clear that it's diagnostically that important. There's theoretical reasons to believe it might be. If there's metastatic disease within the liver, then presumably there's also a chance that there's metastatic disease outside the liver. So there's theoretical reasons to believe that this might be important, but I'm not sure that it's ever been proven clinically to have a major outcome difference. Now, how do I do it? If I see a dominant mass in the liver and I see additional lesions in the liver that are smaller and look similar, then I might speculate that I'm looking at an HCC that has metastasized elsewhere in the liver. On the other hand, if I see different tumors in the liver and they all look different, some have fat, some don't have fat, some hyper-enhance, some don't hyper-enhance, some have nodule and nodule, some don't, etc. They all look sort of different. Then I might start speculating that I think I'm seeing multicentric hepatocarcinogenesis rather than metastatic disease. But LI-RADS does not address these issues, as I said, because one, we don't yet have the scientific evidence to tell us exactly how to do it, and two, the actual relevance for clinical outcome is uncertain. But that's a great question.
Another question from Juan Manuel. He's saying what? Cirrhosis based on, but you can speak Juan if you want. Juan Manuel Perez.
Yes, Claude,
Yes,
thank you very much. I'm Juan from Colombia.
Great,
Hello.
Juan.
Hola.
So my question is, cirrhosis is diagnosed based on pathology, FibroScan, elastography or imaging?
Oh, that is a great question. Khaled, you have assembled an audience of people with great questions.
Well,
this is
those are representing the globe, my friend.
Yes. How to make the diagnosis of cirrhosis is not so easy. And it's something that we're working on, and we're actually thinking of forming a working group to help define this. Historically, what we've done is that if the clinician tells us the patient has cirrhosis, then we accept the diagnosis.
One second, please. 1 second, Claude. There is an echo, so I assume one of us is unmuting him or herself. So please mute yourself. Okay, go ahead, Claude. You can start over, please, because there was
Yes. So it's a great question. How do you make the diagnosis of cirrhosis? So as radiologists, it's very difficult sometimes for us to make the diagnosis of cirrhosis. If the clinician tells us the patient has cirrhosis, then we usually accept the diagnosis of cirrhosis. And how the clinician makes the diagnosis is also a little bit challenging, but let's leave that aside for right now. Now, let's say the clinician does not tell us the patient has cirrhosis, and we see a liver that looks nodular, and maybe we see some ascites. And we know that the patient has a risk factor for cirrhosis, such as alcohol consumption or obesity or hepatitis C or something. Well, in a situation like that, you can use LI-RADS provisionally, and you can say that based on the imaging features, I suspect the patient has cirrhosis. And if the patient in fact has cirrhosis, then this is a LI-RADS 4 or a LI-RADS 5. But I would encourage you to be very cautious with this, because there are situations where the liver can look nodular and where there can be portal hypertension and even ascites and splenomegaly, and there may not be cirrhosis. An example of this is diffuse nodular regenerative hyperplasia, which on a CT or MRI or ultrasound can look exactly like cirrhosis, but there actually is not cirrhosis in the liver. And those patients are really not at very high risk at all for developing HCC. And if you call HCCs in those livers, you'll be wrong. I would say that this is a very controversial issue. This does not have a simple answer. I wish it did, but it doesn't. I would caution you as a radiologist not to make a definite diagnosis of cirrhosis without speaking to the clinician who might have the composite clinical picture. It's difficult in the year 2020 for radiologists to make the diagnosis of cirrhosis based on imaging alone. So I'm sorry that I can't give you a more satisfactory answer other than say that you're asking a great question, and this is an area where LI-RADS needs to develop more evidence.
So we have also Raj. What's the complete name here? Let me read it, because I ask everyone about the name in order to properly introduce. So Raj is practicing, Raj Hilavar. He's practicing in Bangalore, India. And Raj has a question for you, Claude. Raj Hilavar.
Dr. Claude, my question is there a plan to develop imaging algorithm for detection of benign liver lesions like FNH versus adenoma? Is there any plan to develop such an algorithm?
Yes. So Maxime Renaud, who's a radiologist in France, is leading a working group that's trying to develop imaging criteria for benign processes such as focal nodular hyperplasia, hemangioma, focal fat deposition, cyst. So we're starting with a few entities like that, and then over time we might expand to more complicated things such as hepatocellular adenoma, but we're going to start with simpler things like focal nodular hyperplasia, cyst, focal fat deposition, hemangioma, maybe I mentioned that already, and things along those lines. If you're interested in contributing to that, let us know. and maybe we can find a way for you to contribute to that, but we're working on it.
So Raj, you
Thank
can
you very
email
much.
me and I can convey it to Claude. Thank
Sure,
you.
I'll email you. Thank you very much.
Last question. We have two questions, so I would defer one of them to the lecture of Katie Fowler on Wednesday. Dua is asking about how to differentiate between multicentric HCC from hypervascular metastasis on top of cirrhotic liver. I would defer that to Wednesday lecture with Katie Fowler. Muhammad Bukhari, I think I know that guy. He's a good friend in Jeddah, I think. He's asking a long question. I will let him speak. Muhammad, that's the last question. Muhammad Bukhari.
Yes, this is Mohammed. Hi, Dr. Claude. Hi, Dr. Khaled. Thank you for your time and great lecture.
Thank you.
In the process of making, I'm going to read my question very fast. In the process of making our report more unified and focused on HCC probability, do you think that we are, as radiologists, losing over time our ability to diagnose certain entities in the liver? I mean, sometimes I face cases where I just say, is it LR3? Is it LR4 or LR5? If it's not LR4 or 5, I'm just gonna recommend 3 months follow-up. So what do you think?
I'm sorry, so your question is that if it's not an LR4 or LR5, does it matter? Is that what you're saying?
Exactly. So sometimes I face cases where I just ask myself if it's LR3, LR4 or 5. If it's not, it really doesn't matter to me because I'm just going to recommend 3 months follow-up. So in the essence of that, I think I'm not focusing on a diagnosis on everyday practice. Today, I just think about the LR category. So what do you think? Is that the right way to go?
I think the important thing is that is that LI-RADS allows you to communicate clearly to the clinician and to the patient and to your other colleagues what you think the entity is. To me, there's a difference between a LI-RADS 3 and a LI-RADS 2. So a LI-RADS 3, I would probably, continue to follow with a CT or an MRI in some fashion, possibly in 6 months. But if I think it's an LR2, then I might return the patient to surveillance with whatever modality they're getting surveillance. And in most of the world, that might be an ultrasound. So if I see a LI-RADS 2, and I'm pretty sure that it's benign, then I don't even think I need to follow it with a CT or MRI, and I would return the patient to surveillance. So to me, there is a relevance about whether it's a LI-RADS 2 or a LI-RADS 3, because I do think it affects the management. Now, in terms of what the entity is, I think that we're working on this because a lot of LI-RADS 2s and 1s are typically benign, and so this is where that working group that Maxime Renaud is leading will become useful, is to actually start developing criteria to allow radiologists to confidently diagnose benign entities. Anyway, I don't know if I'm answering your question, but I just want to say that we are interested in tackling the benign entities in a more granular, in a more comprehensive fashion than we have until now. So please stay tuned for that.
So thank you very, very much, Claude, and thanks everyone for making this such an inspiring session. I'm really inspired by the attendance of people from all over the world, great colleagues from South America, Middle East, Europe, Asia, and it's really nice. And Australia and New Zealand too are represented. Europe is presented. So thank you very much for attending.